Hi, I am Tessa Collins. I'm the medical director over at the Perioperative Care Clinic at Providence Portland Medical Center. And I'm here today to review the Oregon Region's pathway for patients who test positive on their preoperative screening COVID test. So this first slide looks kind of busy and scary, but I'm going to really make it simple for people. This is attached and part of the policy, so when you have questions, you can go in and actually directly review this pathway to figure out how you should manage your patient. But it really comes down to this very simple statement, which is that your elective surgery procedure should be delayed for a minimum of 30 days when you have that positive SARS-CoV-2 test come back on your patient. Now, the reason we are recommending a delay of 30 days is really in an abundance of caution for the safety and well-being of your patient. There has been studies to date that show that there is a very serious increased risk of complications and mortality when we go ahead and do surgery on patients who have COVID-19. So since at the time of the test, we don't know if your patient is going to be one of the lucky asymptomatic patients, or they're going to be one of the patients who in a few days actually could develop COVID-19. We need to give that patient time to see how things are going to go. And we actually have had cases that get both scenarios, who've remained asymptomatic that whole time, but also people that have a few days later developed very serious disease. So if your patient remains asymptomatic, things are pretty simple. At 30-day mark, you can go ahead and proceed to the OR. If your patient becomes one of the people who goes on to develop symptoms, what we want you to do at that point is delay 30 days from the point that those symptoms resolve. And this is particularly true if the patient develops lower respiratory tract infection, because that really takes time to resolve and the risk of post-op pulmonary complications to go away. And then we'd also like, if the patient does become ill, for you to get medical clearance before you schedule your patient for surgery, since there should be some sort of workup to make sure the patient is truly ready for an elective procedure. So we know that not everyone can be pushed out for 30 days. And so if that is the case, we would like, if possible, that the case be at least delayed to get the patient through their isolation period, which is the time that they're infectious. And if possible, we would prefer we don't bring people into the hospital and expose other patients and the healthcare workers to a potential infection. So if we need to go ahead, what we like the surgeon to do at that point is document medical necessity and the need to proceed outside of our policy of 30 days. And if at 30 days, the banner that's on the EPIC chart that tells us all this patient is a contagious infectious risk will fall off. But if you are coming in any sooner than 30 days from that positive test in EPIC, it has to be removed by infection prevention at your hospital. So in order to do that, they will need the information about the patient that tells you when was the test done, did they develop symptoms, and if so, when did they resolve? So the isolation period, which I'm going to get into a little bit here to define that for you, depends on the presence of symptoms or not, and when was that positive test. And obviously, if the patient meets the criteria for not requiring isolation anymore, we'd want that banner to fall off so that when we see the patient in the OR and on all the other floors, that we don't have to follow the criteria that we've developed for patients who are potentially contagious. And then no repeat testing is necessary. Our previous policy had a test-based strategy for determining continued infectiousness. But as I'm going to review in this talk, a positive test does not mean an infectious patient. And so the CDC has recommended moving away from a test-based strategy and using this time-based strategy, which I'm going to get into in quite a bit of detail here in a moment. So this was a nice article that was in the New York Times called Charting a Coronavirus Infection. And I thought it did a really nice job of explaining the time from onset of that exposure and then the development of COVID-19, and has some nice graphics. And the one you're seeing here is the first one that I borrowed from them. There's a nice link at the bottom of this slide that you can go in and actually read the original article. I'm going to call your attention here to the incubation period, and we're going to talk about the difference between quarantine and isolation. So quarantine is what we do with people who have had a high-risk exposure, and we are basically keeping them away from other people while we see what happens. Not everyone who's had that exposure is going to develop a disease, but if they do, it can take 2 to 14 days before that patient will develop symptoms. And so that is why we have a 14-day quarantine period where people have to wait and see what happens. A high-risk exposure has been defined by the CDC as a time period of greater than 15 minutes and a close distance less than 6 feet and with someone who's been known to have COVID and be in their infectious period. So this slide is showing what's going on with the viral load during the time from that onset of exposure to symptoms and recovery. And so you've got your exposure, you've now got virus that's beginning to replicate, and the viral load is starting out low and going up and peaking and then coming on down. Now this is really representative of what type of infection most people get, which is mild to moderate. And so the exposure time early in the low viral load period, you're not going to pick up RNA and have a positive test. And then as the viral load peaks, you're in an infectious period and a high viral load period. And then 1 to 2 days before you develop symptoms is what I want to call out here on this slide. You actually are quite infectious but have no symptoms. And that is why this virus is so effective at spreading everywhere. This slide is basically just showing the same graphic in a mild to moderate case, what is happening with the viral load and your symptoms versus a severe case. So, approximately 80% of the people are going to have a mild, moderate case. Severe cases, and these are the patients that are typically hospitalized, the viral load goes up and it stays up and for longer. And the patient is typically, that infectious period also has a longer tail. And we'll get in a little bit more to that when we talk about testing. So this is showing when the tests are done and positive and where that viral load is peaking. And so I'm going to get into this on the next slide, just talking to you about the 2 types of testing that we do for COVID. And so there's rapid antigen tests, and then there's the PCR test. And what you can see on this slide is the PCR tests tend to be picking up virus for a longer period of time, both on the front end and the tail end of infectious period, whereas the rapid tests tend to be positive in a more narrower time frame, but also typically when you're infectious. And they both have their pros and cons. So the nice thing about the PCR tests is they're, especially the ones we're using in our hospitals, not the rapid ones, which there's a little more concern about the sensitivity. These are highly specific, which means the likelihood of a false positive is quite low, and highly sensitive, so the likelihood of a false negative is also low. It does require special lab processing equipment, so they're expensive, and like I said, the window for detection is longer. The antigen tests have the advantage of being rapid, inexpensive. You don't require special lab processing. A lot of these can be, the turnaround time is like 15 minutes. And like I said, the likelihood of them being positive is in that narrow window when people typically are infectious. It has more false negatives though. So if a patient has symptoms consistent with COVID and they get a negative result on that, it is recommended that you go ahead and retest that patient with a PCR if your suspicion is quite high. The final type of testing is antibody testing. These are blood tests, and they should not be used for screening or diagnosis. These are your antibody responses to the viral infection, and they don't begin to really become positive until about a week after the onset of disease. And at 50% of the people are going to have positive antibodies at 7 days after, and then at about 2 weeks, pretty much everyone will have a positive antibody response. So this slide is just to show you again that there is a period of time where you can have a positive PCR test where right before you're infectious, and then a much longer tail actually after you're infectious. So it can pick up those RNA fragments during a period where you are no longer infectious. So this is a graph from one of the studies that was used to come up with the CDC policy about how long is this infectious period. And so there were several studies, and this was repeated over and over again, that showed in patients that had mild to moderate disease, when they tried to grow the virus in a cell culture, they repeatedly could not get it to grow past day 8 of symptom onset. So our SARS-CoV PCR test tells us you've got some RNA in there, but this is actually, is it viable and is it infectious? And this was repeated again and again in mild to moderate diseased, no longer than 8 days. And that's where the 10-day recommendation comes from. Now, in patients that had more severe disease, meaning hospitalized patients or patients that were immunocompromised, that tail lasts a bit longer for infectiousness, and typically 10 to 15 days is more typical for the infectious period. And hence, for severe disease or patients who are immunocompromised, it's 20 days from the time that those symptoms are onset that patients can have to stay in isolation. So now we're going to talk about what the specific CDC recommendations are for removing patients from isolation. And I highlighted for you at the top of this slide, just to bring it home, that given what they found, which was this consistent, continuous testing positive, even outside of the infectious period, when we were using a test-based strategy, we were keeping patients isolated sometimes for weeks before we could get those 2 negative tests 24 hours apart. And so because of what I just discussed in these other slides, the CDC now recommends we do not use a test-based strategy. We use a time-based strategy, which is related to what is the infectious period. And in mild to moderate disease, repeated studies have shown that you cannot get viable virus from patients outside of 8 days, so they've set it at 10 days. So if from the onset of those symptoms, 10 days later, the patient can remove from isolation as long as they haven't had a fever for 24 hours. So it's whatever's longer. And also that their symptoms are improving. So if a patient is asymptomatic, which of course most people are not testing asymptomatic patients except in the case of surgery like we're doing, then it's from the point of that positive test, 10 days. That's when patients are released from isolation and no longer need any special precautions. If you're immunocompromised or you've had severe critical illness, that number, they're saying in their recommendations 10 to 20 days. At the end of this, I'm going to review our hospital policies for de-isolation. We're not giving a range. We're saying 20 days. So if the patient's hospitalized, severe immunocompromised, we're going to say 20 days. And then you can't have had a fever or be on any medications for fever. 24 hours, it has to be resolved. And then an improvement in their symptoms. Now, it's not resolution of symptoms, which I think in the early days was on this, because we know that people can have some fatigue, some persistence in a cough that sticks around for a while, but at least an improvement in those symptoms. The definition of immunocompromise is very specific here, and I just want to call this out because I definitely have been called about this from people who are concerned, well, our patients have end-stage renal disease, or they're elderly, or they have other diseases that we feel make them immunocompromised. But the nice thing is the CDC has been very specific on their definition of what we mean by that. And so if the patient's on chemotherapy for cancer, they are within 1 year out from a bone marrow transplant or an organ transplant. They have untreated HIV infection with a low CD4 count. Steroids, so high-dose steroids for greater than 14 days, that's 20 milligrams is the cutoff for that. And that is how we define that. This is a copy of the de-isolation policy that is in place at our hospitals, and it really just mirrors exactly what I went through with the CDC guidelines. So asymptomatic patients, you are released from isolation 10 days after your first positive COVID test. And that honestly is the majority of the patients that we've seen for the pre-surgical screening. Most of them are typically staying asymptomatic. And then if you develop mild to moderate, it's 10 days. And you have to have not had a fever in all of these, by the way, if you develop symptoms for 24 hours. And then 20 days for immunocompromised and critical illness. So this is another question that has come up, and is, can patients become reinfected with COVID-19? And it's really interesting because if you go to the CDC's website right now, it will say there have been no documented reinfections. And since that was published and they haven't updated it yet, that is no longer true. There is at least 2 2 for sure. In this slide, this is typical of COVID and all the information out there, just from when I made this slide last week to re-looking this data over today, there were several more case reports that look like they've been confirmed. And this 25-year-old man has been peer reviewed. So we know the first one was in August, a 33-year-old man in Hong Kong became infected a second time, and then this 25-year-old man in Nevada. And there are several others that I looked at today that are being confirmed, but they actually have to use genomic sequencing to confirm these. And it does look like it can happen. Are there a lot of cases at this point? No, but clearly it's possible. There seems to be we don't know how long antibodies and the immune response persist, but there is evidence from the data on SARS-CoV-2 and other coronaviruses that should suggest at least several months. And then there was a good recent study in Iceland in the New England Journal where they measured antibodies in the serum samples of almost 1,800 patients that had recovered from SARS-CoV-2 infection, and 91.1% were still seropositive at 4 months after diagnosis. So based on that, the recommendation is do not retest patients within 90 days of a SARS-CoV-2 PCR test, except one little caveat. If a person has COVID-19, recovers and is completely asymptomatic, and then represents with, what looks to be, again, a full-blown COVID-19 diagnosis, then maybe consider retesting them in that scenario. But what we're doing at our hospital for patients who we screen have a positive test is we, like I said, delay them for 30 days if that's at all possible. If the surgeon wants to document medical necessity and really feels like that's too long, at least meet the criteria to come out of isolation in your infectious period. And then do not do any retesting. So because we know these tests can keep coming up positive, even though patients are no longer infectious, we are not going to retest them within 90 days. And then finally, I just want to mention the antibody testing again and just remind you, it's not useful for detecting active infection. Those antibodies don't start to come up until, a week after onset of illness and really a couple weeks before most people have antibodies. This is just a graph showing when those different peaks are happening based on the testing. And again, just showing the antibodies come in late. And I do want to say that everything we advise and tell you about COVID has to be a very fluid response. There's a lot of information that comes out all the time, and we just keep adjusting based on new information. And this is our best recommendations given the data as we currently have access to at this moment. Thanks.